everyone, Dr. G here. Welcome to another episode of Discussions with Dr. G. Today we're diving right into the anxious abyss, yet anxiety disorders. I mean, who doesn't love a fun trip through an overactive nervous system, right? So let's start with what's actually going on in the body. Anxiety disorders are basically like your brain's ultimate prank. Prolonged, exaggerated fear that just totally hijacks your day-to-day life. Instead of, oh, I saw a snake, that seems legit, your body's like, alarm bells, alarm, alarm, all the time, for no reason, literally. At the heart of this chaos, you've got your sympathetic nervous system, the fight or flight headquarters. That's the culprit behind the racing heart, high blood pressure, and that hyper alert feeling like you drank 3 energy drinks. Not that I've ever tried that in nursing school. Nope, not me. Nope, never. Anyway, then you've got the hypothalamic pituitary adrenal or HPA axis, which is pumping out cortisol like it's free samples at the grocery store, which if it sticks around too long is actually bad news for your heart, your immune system, and even your stomach. Let's not forget the SAM system, basically your adrenal factory, cranking up norepinephrine and epinephrine for that full body hyperarousal experience. Neurotransmitters? Sure. They're a mess in anxiety. We see low GABA, that chill out chemical, while glutamate and norepinephrine are out here doing a rave. Plus, serotonin and dopamine are acting up too. Toss in stress, trauma, maybe a little too much caffeine, and even certain medications like corticosteroids or thyroid medication, and you've got yourself a perfect recipe for anxiety. Now let's talk symptoms. Physical stuff, heart palpitations, muscle tension that makes you feel like you did CrossFit in your sleep, and good old insomnia. Psychologically, you might be irritable or just unable to focus, that thing where you read the same email about 5 times in a row. Functionality, anxiety means you're not killing it at work or school, maybe pulling away from friends, or, not uncommonly, learning an unhealthy coping mechanism like substance abuse. I've seen anxiety come with a side of depression, sometimes cardiac issues, and even metabolic problems. Okay, story time. My very first patient is a new nurse, came in mid-panic attack, white-knuckling the gurney. My, quote, professional self thought, I'll just use that calm, reassuring nurse voice they teach you in school. It worked until, my own caffeine kicked in and I suddenly sounded like a squirrel on Red Bull, more so than Florence Nightingale. Lesson learned, project calm, even if your own brain is running a marathon. So let's shift gears a little bit and talk about the treasure chest of pharmacology, also known as what meds do we actually use for anxiety? The all-stars here are definitely the SSRIs and SNRIs. If anxiety had a most likely to succeed yearbook, these would be it. Solid first line for generalized anxiety, panic disorder, PTSD, you name it. They work by getting those serotonin and norepinephrine levels back into a less chaotic mosh pit zone. So, good old SSRIs like sertraline, citalopram, and escitalopram. You'll see these everywhere. They block serotonin reuptake, so more of that happy juice floats around your synapses, making people, hopefully, less anxious and mopey. I love them because there's less sedation and fewer anticholinergic side effects than the, let's call them, vintage antidepressants. You do want to watch out for serotonin syndrome, though. I once told a student to imagine serotonin syndrome as a party that's gone off the rails. Everyone's sweating, agitated, jittery, and confused, and you absolutely want to end it, but you can't. It's literally the worst party ever. And it can get real dangerous real quick. Also, you need to watch for the rare stuff like hyponatremia. Citalopram loves to mess with older folks in that way. And the boxed warning here, suicidal ideation, especially in adolescents and young adults. Don't forget it. SNRIs, like venlafaxine, they add norepinephrine to the mix so you get a little more zing and focus, which is nice if you've got anxiety with a side of depression. But venlafaxine can shoot up your blood pressure as the dose goes up. So it's not just set it and forget it. You got to monitor the BP. Also, you want to check for bleeding if the client's popping anticoagulants. And of course, no mixing with MAOIs because serotonin syndrome likes to make encore appearances. Nursing pearls. Titrate slowly. Never stop these abruptly and educate on what to do if they miss a dose. Honestly, I sometimes forget if it's to take it ASAP unless it's already almost time for the next or just skip it. Either way, don't double up. Well, that's the gist. SSRIs, SNRIs, they run the show. But let's talk about what you do when someone can't tolerate those or they need a little extra help. Let's just say someone can't wait the 2 to 6 weeks for the SSRIs to kick in, or they need fast relief for a specific event. For instance, a big speech, a first date, a final exam. This is where benzodiazepines show up and are actually super effective. But you want to use these like you use hot sauce, sparingly. They pump up GABA and make everything just a little more chilled out, for better or for worse. But too much for too long, and that's when you end up with dependence issues, potential withdrawal symptoms, and even respiratory issues, especially if there's a history of substance misuse. When you think benzos, think alprazolam, lorazepam, diazepam, that whole crew. Again, great for panic disorder, acute anxiety, alcohol withdrawal, or when you just need them short term to chill out for procedural things. But the big caveat, they do love to sedate, cause dizziness, and maybe even constipate. Oh yeah, and we're not stopping these cold turkey because they could lead to, you got it, seizures. So again, short term, maybe 4 months max, okay? And don't even think about tossing them in with opioids unless you want to be collecting case studies on rapidly fatal CNS depression. For elderly clients, fall precautions. Trust me. I've seen enough walkers to last a lifetime. Buspirone, though, honestly, is my favorite underdog. It works slowly, think like 2 to 4 weeks, but hey, there's no risk for dependence or withdrawal. It doesn't sedate. It does have a downside. You have to take it multiple times a day, and for the love for all that is holy, no grapefruit juice. I don't make the rules, people. I just repeat them. And grapefruit is out. Now, the buspirone nudges serotonin in a more polite, less sedating way. So, if you want long-term control but no dependency drama, this one's your friend. Slow to act, like I said, tortoise in the anti-anxiety race, but it is safe for people who may struggle with substance abuse. Now, for the people who can time their anxiety to big moments, okay, these are the lifesavers for performance anxiety or prepping for karaoke. Just kidding. Beta blockers, like propranolol, let you keep your cool without all the jitters or sweats. They work by tamping down the heart pounding, shaky hands, and you do have to be careful with people with asthma or diabetes. You can also use antihistamines like hydroxyzine. This is another handy as needed for anxiety, though it does have the side effect of drowsiness. So if you can, you could have your patients take it at night. There are atypical antidepressants like mirtazapine, which is like the sleep fairy. Lots of sedation. And bupropion, which you absolutely do not want to give to anyone with a seizure or eating disorder, or to folks who are in alcohol withdrawal, unless you're interested in playing with fire. All right. Sneaky GABA analogs. They have their own drama. Pregabalin is sometimes used off-label. It's good for pre-op anxiety too, but it can be habit-forming and can cause withdrawal if stopped suddenly. I mean, who said behavioral health wasn't exciting? Finally, our lovely MAOIs. Mainly for folks who have not done well on anything else. But with these, you might as well carry an encyclopedia of medication interactions and make a vow to never, ever touch cheese or wine again. Thanks to that whole tyramine situation, tyramine-rich foods plus MAOIs result in hypertensive crisis, which, honestly, guys, that's not even funny. It's truly no joke. Quick word on when not to use these. Benzos are a hard pass if your patient has a history of substance misuse or a history of respiratory depression. SSRIs and SNRIs don't mix with MAOIs, and be careful with anyone who has bipolar disorder. As for beta blockers, they're a nightmare if you have asthma or bradycardia. All right, so that's the menu of medications. Here's where things get spicy. Each one comes with their own fun set of side effects, as you have well heard. Each one has their own weird contraindications, and of course that's going to lead to nursing headaches. So let's talk about what really keeps nurses up at night when it comes to these anxiety meds. The side effects and safety, right? Most common: sedation, GI upset, dizziness, maybe a little bit of sexual dysfunction. Not fun, but manageable. The scary stuff is that serotonin syndrome, especially when folks mix meds. Trust me, you do not want to see that. Hypertensive crisis, benzodependence, and yes, suicidality. Big boxed warning, especially in younger folks starting on antidepressants. You, as the nurse, are going to be monitoring vitals, especially when folks are on SNRIs or propanolol, because blood pressure and heart rate can do funky things. You're going to watch out for withdrawal or new mood changes. And if they're on SSRIs or SNRIs, keep an eye on their metabolic labs. Patient teaching is honestly where we work our magic. Explain that SSRIs and SNRIs do not work overnight. They take 2 to 6 weeks to start working effectively. You have to manage your patient's expectations. Benzos, only for now, not forever. And no alcohol or opioid cocktails. Buspirone, every day, same time, no weird fruit juice. Propanolol, timing is everything. Take it about an hour before your big terrifying event. And here's a little teaching trick I used once. My all cats analogy. Imagine you have a house full of cats and you suddenly stop feeding them. They're going to be real mad, real chaotic, scratching up the curtains. That's your brain on abrupt SSRI withdrawal. It's not good. Slow and steady wins the race, always. Double check your meds. Hydroxyzine and hydralazine sound a lot alike, but your patients won't thank you if you mix them up. Prioritize safety and recognize when symptoms might be anxiety itself versus a medication effect, and measure real outcomes. We want fewer panic attacks and more sleep, resulting in happier people, not just fewer side effects. Nursing responsibilities start with a good assessment. Stuff like the GAD-7 really helps track what you're dealing with. Definitely screen for suicide risk and substance abuse. Monitoring matters. Watch for your red flags. If your patient gets agitated, feverish, starts having tremors, or just seems off, that could be serotonin syndrome, so act fast. And encourage all the non-pill solutions too. Therapy, exercise, sleep hygiene. You know, adulting skills. All right, let's do our cheat sheet to wrap this up. SSRIs and SNRIs are our first line, and you got to know your monitoring game. Benzos are short-term, and never forget how ugly withdrawal and misuse can be. Buspirone, hydroxyzine, and propanolol make great adjuncts, just remember their quirks. Watch for the big three: serotonin syndrome, withdrawal, suicidality. And if you forget everything else, remember, nursing vigilance saves lives. Assess, teach, act early. And yeah, meds are important, but so is understanding how they fit into your patient's world. Thanks for sticking with me through all the med madness. Next time, we tackle a whole new class, probably with more cat stories. I'll see you then.